Fine, sir.
Okay, good. In the previous lesson, we have started discussing about CKD, and we have seen about the definition, classifications of CKD, and we have also seen about different risk factors for CKD. Today, I'm going to take you through about the pathophysiology of CKD, clinical presentation, as well as management of CKD. So, as much as you can try to follow, because I will be fast and I will focus only at the most important points because of time. So, remember, there are a number of factors that can actually cause initial damage of the kidney. Then after that, what will happen? When there is a damage of the kidney, that means there is also loss of nephron. So when there is loss of nephron, what will happen? The remaining nephron undergo hypertrophy, like in the form of like a kind of like compensation. So when they are undergoing hypertrophy of the remaining nephron, they can compensate the loss of renal function and nephron mass, and as a result, they can increase the GFR and tubular function in the remaining nephron. So initially, by undergoing hypertrophy, they can actually maintain the kidney function. Then, but the problem is these initial changes can preserve many of the clinical parameters of renal function at the moment. But the problem is, as the time progresses, what will happen? There is increase in glomerular capillary pressure. This capillary pressure is usually mediated by angiotensin II. So remember, angiotensin II is a very potent vasoconstrictor of both afferent and efferent arterioles, but it is actually preferentially have a higher affinity to constrict the efferent arterioles. So when there is an increase in the efferent arterioles, what will happen? There is an increase in glomerular capillary pressure. Then, as this capillary pressure increases, what will happen? The basement membrane of the glomerulus, that is like the mesh will increase, and it allows the filtration of protein in the glomerulus. So initially the compensatory mechanism is very important, but the major problem is as a result of compensatory mechanism, there is activation of RAS system. So this RAS activation increases what? Angiotensin II, then angiotensin II can increase glomerular capillary pressure, and ultimately this pressure can dilate or expand the pore size. So this expansion of the pore size allows filtration of the protein. But the major problem, when proteins are filtered and reabsorbed in the renal tubule, it can activate different inflammatory mediators, including complement activation. So because of this reason, the kidney effect or the damage to the kidney can actually increase. So this in turn causes interstitial damage as well as scarring within the renal tubule, and this leads to loss of more nephron. If the basement of the glomerulus undergo expansion and it allows more protein, this inflammatory reaction allows loss of more nephron. That is why proteinuria is really not required, because like there is a lot of inflammatory reaction at the result of leakage of protein. So this ultimately leads to progressive loss of nephron. So, and it reaches at the point where the remaining nephron will no longer function to maintain the clinical stability, and renal function will decline. So this is where we said there is a progressive damage. So as long as we are not actually controlling the progression of the disease by preventing or by treating the proteinuria, the disease will progress, and the patient will have advanced stage of renal disease. I think this is a summary of what I have said, maybe you can read this one. Then, what are the clinical features of chronic kidney disease? Stage 1 and stage 2 are generally asymptomatic. So most of the time, you don't really see any significant clinical presentation when a patient is having stage 1 and stage 2 CKD. And stage 3 and stage 4, they are associated with minimal symptom, but in stage 5, the patient is usually asymptomatic. So when you look at this diagram, you can actually even see if the kidney function is deranged, it can almost affect all systems. So on the CNS, you can say the patient can have confusion, seizure, and coma because of uremic toxin. So this toxin will be accumulated in the brain and causes a lot of damage. This is characterized by confusion, seizure, and coma. Then, when you look at the effect on the blood parameter, it can cause anemia as well as platelet abnormalities. Like the uremic toxin can affect the platelet and it can actually cause bleeding. Then apart from that, because kidney is important in the production of erythropoietin, so if erythropoietin production is reduced, the patient will have anemia of chronic disease. So the patient can have anemia. When you look at on the renal system, the patient can have polyuria and sometimes even inability to concentrate urine at night time. We call it nocturia, can also occur. Then, as a result of derangement in the renal function, the kidney is not able to maintain fluid balance. So there is high probability of having sodium and water retention. Then apart from that, if a patient is having kidney problem, there is a possibility of having even hormonal imbalances, despite the exact mechanism is not really known. Like some patients can have oligospermia, there is ultimately causes even infertility. So this is the hormonal imbalances as a result of the uremic toxin. Then apart from that, on the bone, it can cause osteomalacia. Remember, when the kidney function is deranged, it is not really like absorbing calcium. So what will happen? The parathyroid gland, which is the principal gland that control the calcium metabolism, will be actually activating bone resorption, and ultimately the bone mineral density will be low. And there's a possibility of having bone pain. So this is due to like hyperparathyroidism. Then when you look at the effect of the GIT, it can cause nausea, vomiting, and even anorexia. And ultimately, the patient will end up having a weight loss. This is actually due to the effect of the toxin. Then even it can cause peripheral neuropathy. So you can actually even see how renal problem is actually affecting multiple organs. Okay, then maybe now we can actually see in detail the clinical presentation for this condition. So polyuria and nocturia is very common. Remember, the polyuria is due to the osmotic effect of high serum urea. Like if the blood urea nitrogen is very high, it has osmotic effect and ultimately causes polyuria. Then apart from that, the physiological effect of nocturnal antidiuresis will be lost because of kidney derangement, and the patient will end up having actually bleeding at night time. We call it nocturia, like when they are sleeping. Then, apart from that, because of protein loss in the urine, the patient will have like foaming of urine. Remember, normally, did you see when you are actually like when you are actually pouring alcohol to the glass? Huh? So that hypothesis is equivalent to like a freezing of the urine or foaming of the urine. You can actually even see how the urine look like. So if the urine forms like this, most likely there is protein in the urine. So this is an indicators of proteinuria. Then, remember, in case of proteinuria, the prevalence usually increases with the severity of the kidney damage. So, if a patient is actually having a pronounced proteinuria like greater than 1 gram, most likely there is a significant damage in the glomerulus. That means like there is a massive loss of protein is mostly referring to there is a glomerular damage. Then apart from that, the patient can have hematuria. So this hematuria is mostly results from the lower urinary tract pathology such as blood lesion as well as glomerular lesion. Then you can actually even see the patient can have hypertension and fluid overload. So this is due to due to sodium and water retention. So ultimately, the patient will end up having anasarca, like the patient can have even anasarca, like total swelling or like the whole body will be edematous. I don't know you came across this kind of patient. It is very common in advanced stage of the disease. Then, what we don't like with a kidney derangement is the accumulation of the uremic toxin. Remember, many substances, including urea, creatinines, are normally excreted in the kidney and they will be accumulated when there is kidney function reduction. So there are a wide range of uremic toxin in the blood, but most of the time, the degree of the toxin is usually estimated by the blood urea nitrogen level or the creatinine level in the serum. So if the blood urea nitrogen level is very high, means we can say the patient is actually having a lot of uremic toxin, because this is just like an indirect measure of the toxin available in the body system. And mostly the patient have symptomatic uremia in very advanced stage of the disease. Remember, those uremias, they can actually cause a lot of presentation. If the toxins are accumulated, the patient can have like loss of appetite, even nausea, vomiting, and even sometimes you will see there is a foul taste. So like the patient is actually sensing a very bad taste. This is actually because of uremia. Sometimes even they can actually even breathe it. And then, apart from that, the uremia can also cause pruritus without underlying cause. So the patient will be continuously itching. So this itching, in case of a kidney problem, is because of uremia. But remember, the bile pigments, even bile pigment accumulation in liver patients are also responsible to cause itching in liver patients. So you can actually even see itching is also very common, and we'll discuss how we are managing itching due to uremia. Then, in extreme cases, when the like when the uremia is very high, like it can actually even crystalline. There is actually a formation of crystalline urea that can be deposited on the skin, and we call it uremic frost. So this uremic frost is like a white, a white, we can say it's just like a white appearance on the earlobes on the forehead, as you can see in the next diagram. So this is when in severe cases, like the urea can crystallize and deposit on the skin. And the patient, you can actually even, it seems like it's a powder is actually is like, it's just like a kind of powder particles on the face and even throughout the body. But it is very common in these areas, in the forehead, in the earlobes, and etc. So in advanced stage, and if the patient is not treated very well, they will encounter this condition. And it is very common. I've seen quite a number of patients who developed this condition as a result of CKD. So this is, we call it uremic frost due to the urea is crystalline and deposit in the form of ice, small ice or small white powder appearance throughout the body. system. Okay, so this is one clinical presentation, by the way, when a patient is having severe uremia. Then the patient can have anemia. So anemia is very common, especially in advanced stage of the disease, stage 4 and 5. Remember, this is anemia of chronic disease, and mostly it is due to deficiency of erythropoietin. Erythropoietin is like the main stimulus for RBC production. And the fall in hemoglobin is very slow and insidious process, and ultimately due to decline in the renal function. So what causes anemia in CKD patient? Remember, the toxin can even reduce the survival time of the RBCs, and they can even cause marrow suppression. This is due to uremic toxin. Then apart from that, there is a possibility of iron and folate deficiency associated with poor dietary intake or increased loss, for example, due to GI bleeding. So because of uremic bleeding, they can actually lose a lot of significant nutrients, especially when there is a blood loss, there is also loss of iron, so the patient can have anemia due to this condition. And apart from that, because of the toxin, the appetite of the patient is suppressed, so they do have most likely poor dietary intake that leads to anemia. But the principal cause is mainly due to inadequate secretion of erythropoietin. So erythropoietin is a potent stimulus for the bone marrow so that the bone marrow can actually produce RBCs. So if the kidney function is deranged, it means that the patient will end up having anemia. Then apart from that, I will come later by day, as a result of like low serum calcium level, the parathyroid gland undergo hyperplasia. So this one even can actually even affect, also reduces erythropoiesis by damaging the bone marrow. Remember, the bone marrow undergo even osteomalacia, and this ultimately even actually reduce the erythropoiesis. So this is even hyperparathyroidism can also increase the risk of anemia in CKD patient. Then, as I mentioned before, there is a bone disease, we call it renal osteodystrophy. So this is due to excessive bone resorption as a result of the kidney damage. We call it a bone disease. So the patient will have bone pain, even including a fracture. So this bone pain is also very common in renal patients. So when you look at, there is a possibility of disturbance of phosphate and calcium regulation in case of renal failure. Remember, we have already at the beginning of the session, we have discussed about the role of the physiological role of kidney. So kidney is important to excrete phosphate, but when there is a renal failure, the phosphate excretion will be reduced and the serum phosphate will be elevated. But this high phosphate can bind with calcium, and this actually reduces the serum calcium level. Then, as a result of low calcium level, which is actually a good signal to activate the parathyroid gland, then the patient will have hyperparathyroidism. As a result, the patient will end up having a bone disease due to excessive bone resorption. Apart from that, renal failure, kidney is very important for activation of vitamin D, especially like the first hydroxylation will be done in the kidney. So if this hydroxylation is not carried out, means like there is no active vitamin D. So vitamin D is very important for calcium absorption in the GIT, and also very important for bone mineralization. So the patient can have even osteomalacia. So you can actually even see the effect of even kidney failure on the bone is very, very high. So you will see these disturbances even when a patient is having a kidney problem. Then, as I mentioned before, because of the toxin, the patient will have some kind of neurological changes, including even inability to concentrate, as well as memory impairment is very very common. Then in the muscle, so because of electrolyte disturbances such as hypocalcemia, the patient can have even muscle cramp and restless leg. So those are the effects on the muscle. Then, as a result of even electrolyte disturbances such as hyperkalemia, so I have already mentioned when we are discussing about AKI, we have discussed about the potassium disturbances because potassium regulation is carried out in the kidney. So you will see this disturbance. So hyperkalemia is very dangerous and it can actually cause cardiac arrest. So especially if a potassium level is above 7, it is a medical emergency. So you will see those electrolyte disturbances when a patient is having CKD. Remember, renal failure, hydrogenation is actually written and even causing acidosis. So even hydrogen ion excretion is usually mediated in the distal renal tubule by the kidney. So if the kidney is not functioning properly, hydrogen ion is written and the patient will end up having metabolic acidosis. So those are the most common presentation when a patient is having a kidney problem. So what are the complications of CKD? So when a patient is having CKD, you'll see fluid and electrolyte disturbance is very common, anemia and metabolic bone disease. Those are like the major complications of renal problem. Then how do we investigate whether a patient is having CKD or not? Look at any signs of anemia, which is very important. And as I said before, whitening of the skin due to crystalline urea, uromic frost is also very common, and you will see any signs of edema. The extremities, sometimes the whole body parts, and also look at in jugular vein in the neck. It is usually distended when there is an edema. Then fish smelly odor on the breath, we call it uremic foetor. So this one is actually because of the toxin. So this is really very common, and sometimes you will see changes in the urine color and the urine become frothy, like alcohol. So this frothy is an indicator of there is a protein in the urine. So maybe next time when you encounter a patient of CKD, you need to ask even critically or maybe look at how does the urine look like. Okay, then look at this one is proteinuria is an indicator of structural damage to the kidney. And we have already said significant proteinuria is usually when the daily excretion of protein is above 300 milligram per day. And if it is between 30 to 300, we can say it is microalbumin urea. Then lab tests, mostly we do blood urea nitrogen and serum creatinine. And as the stage advances, like the level of blood urea nitrogen and serum creatinine will be very high, and the GFR will, is very reduced. So like the difference is normally the degree of the level of those markers are very elevated when the disease is advanced. So those stages are mandatory. Then in advanced stages, by the way, you will see the potassium level will be very high, and the calcium level will be very low, and the phosphate level is very low, very high due to reduced excretion. So those are very common. Then you will see even the bicarbonate level will be reduced. This is due to metabolic acidosis. Okay, then you need to do even complete blood count. So CBC measurement is very important, so that in CBC, because of chronic damage to or chronic effect on the erythropoietin level, the patient will have even reduced RBCs. And mostly by they don't really do the level of erythropoietin level in our setting. Yeah? So they normally measure like CBC, which is cheap and cost expensive. That one is an indirect measures for erythropoietin level. So determining the erythropoietin level is not common. and mostly it is low, but mostly they look at the CBC level. Okay, then urine positive for albumin or protein is very common, and apart from that, there is an increase in parathyroid hormone level. Those measurements are mandatory, by the way, so that we can know whether the patient is having secondary hyperparathyroidism or not. Then decreased vitamin D level. So sometimes we need to do even the serum levels of vitamin D so that we can measure whether it is reduced or normal. And mostly reduced level is very quite common. Okay, good. So those are the investigation parameters we need to look at when a patient is having CKD. Then generally, how do we manage CKD? How do we manage CKD? We do have non-pharmacological as well as pharmacological modalities. And what is the goals of therapy? The goal, remember, CKD is incurable. Like the available treatment cannot cure CKD. So the goal is usually to slow and prevent progression of the disease and to treat secondary complication, of course, to relieve the symptoms are those are the most important goals in CKD patient. So what kind of non-pharmacological modalities you can actually even remember? So potassium restriction. Remember, the potassium-rich diet is not recommended in renal patient because of high potassium level, or the potassium regulation is generally impaired in this patient population. So what kind of food is the patient supposed to limit? I don't know whether you know, like those bananas, avocados, tomatoes, orange juices are very rich in potassium. So if a patient is having a renal issues, generally it is advisable to limit or not to take this kind of food material as much as possible. And you need to actually discontinue all those medication that can increase the potassium level, such as the potassium sparing diuretics. So I'm assuming you know, like all those medications they do have a greater potential to increase the potassium level. Then sodium restriction. Why we need to restrict sodium, and mostly like less than 2 grams if a patient is on hemodialysis, or 2.4 grams if a patient is actually having CKD with hypertension, because sodium can actually increase water retention, ultimately increases even the edema. Then why we need to restrict phosphate? Because the patient is having high phosphate level, so we need to restrict phosphate, which is very important, especially protein-rich diets such as milk, meat, beans. They are good source of phosphate. So in general, phosphate restriction is commonly recommended. Then apart from that, dietary protein. So why dietary protein restriction is commonly recommended? Maybe I need to ask sometimes, why dietary restriction is commonly recommended? Dietary protein restriction?
To avoid the inflammation that happens after it's filtered.
Yes, exactly. Because like in CKD, it's already protein in the urine and the basement is already expanded. So we can say if the patient is continuously taking protein means there is high probability of worsening of remaining nephron. But remember, the patient should be balanced with the risk of malnutrition. So they cannot absolutely restrict protein, otherwise they will encounter even malnutrition. But in a certain extent, they're supposed to restrict protein. So especially if GFR is less than 25 ml per minute, remember, like this one is already like stage 4. So there is a need of benefit, like there is restriction of protein is really beneficial. But if the GFR is above 25, there is no much importance of restricting. So according to the National Kidney Foundation, the recommendation is the recommendation is the patient who are not receiving dialysis, they need to restrict at least like 0.6 gram per kg per day. But the problem is, like, this time around, like, is it really possible to know about our daily intake of protein in our setting? Yeah? Do you know, like, our daily intake of protein in our setting in terms of gram? It's very unlikely. So, what is ideal or what is practical is just normally we need to tell the patient as much as possible to reduce the consumption of protein. Yeah, otherwise it is very hard normally, like, to know how much amount of protein you are taking on the daily basis. But in a way, this is the recommendation.
Yeah.
Yes,
So it's both animal and plant protein.
yes, as long as they are source of protein, yes.
Okay.
Yeah, it's not very easy, but at least you can actually reduce consumption of protein-rich diet, maybe 2 days in a week. If you are actually like meat, meat is a very rich source of protein, like beans. It is actually very rich in protein. So at least consumption of those high rich source of protein should be like reduced so that you can reduce the worsening of the condition. Yeah? But this condition, please do give much attention. The case of CKDs are quite many. There are quite many, and you can't miss any case of CKD. So, as much as you can, you need to know the basic principles of the complications and the management. Okay, smoking cessations are very important, and we mentioned about smoking is one risk factor. It can even cause damage of the proximal renal tubule. So, as much as possible, try to cease smoking is very
So,
yes important.
how is CKD?
Sorry.
How is CKD and smoking related?
Oh, okay. But the exact mechanism is really not known. But they are saying like the chemical substance of smoking can cause damage of the renal tubule. That is what they are saying. Smoking is not really advisable. Then apart from that, you can see about the indirect effect of smoking. Smoking can cause endothelial damage and increase other cardiovascular condition. So as a result, by increasing other cardiovascular conditions such as hypertension, the patient can end up even having secondary complication as a result of the secondary cardiovascular disease such as hypertension or ischemic heart disease and etc. So, but mostly, sorry?
What about alcohol?
Even alcohol can cause even indirect damage. So generally speaking, like the risk of cardiovascular and renal complication is very high with smoking and alcohol. Yes, but it is not really directly related. Remember, alcohol can cause even hypertension. Alcohol even can cause even cardiomyopathy, and the patient even end up with having renal failure. So there is high probability, but there is no direct association between alcohol intake and the risk of CKD. Okay, good question. That means you have read the content. Okay, but for the remaining topics, as I told you before, you have to read in advance. Then, remember, in case of CKD management, we manage the complication as well as we manage the underlying disease. For example, at the beginning of the initiation factor, diabetes is the front line. It is the most well-known risk factor for CKD. So you can say if a patient is actually having, say, like DM plus CKD, optimum blood sugar control is very important. As I mentioned before, high sugar level binds with protein and it produces advanced glycosylation products that have the potential to cause damage of the glomerulus of the kidney. Because of this reason, we need to have optimum sugar level even in diabetic patients. And mostly, we're using insulin. In detail, by the way, we'll discuss when we're discussing about endocrine disorder, like for DM management, we'll discuss in detail. But for the time being, because you have not covered about the hypoglycemic agents Oh, have you covered anti-diabetic medication? I don't think so, unless you did it in medicinal chemistry. Have you covered anti-diabetic medication? I think that is next semester, but I don't know about the medicinal chemistry aspect. But anyways, in CKD patient, insulin is like the drug of choice because this is the most effective treatment modalities in CKD plus diabetic patient. The oral hypoglycemic agents I will discuss later in the next semester is not commonly recommended because of the risk of hypoglycemia and they are excreted in the renal system. So here we need to actually maintain the blood sugar level, and insulin is like the drug of choice. But remember, if a patient is actually having end-stage renal disease, we can use like the management for DM in CKD patient is insulin, but oral hypoglycemic agents like so far we can actually use with dose adjustment, but the recommendation is generally oral hypoglycemic agents in CKD plus hypertensive patients are generally not recommended. So insulin is by far better, but still you need to note the risk of hypoglycemia as a result of insulin because insulin is still cleared by the renal system. It is cleared by the renal system, and a dose adjustment is very, very, very critical. So you will actually get the doses, the dosing schedule in the footnote from this slide. But you need to note low dose, as low as possible. The dose of the insulin should be very low, especially in this stage renal disease. But do you know sometimes they are not even treating the sugar level when a patient is having end-stage renal disease. They are saying even despite they are in this state, despite the patient is having diabetic, they still produce some amount of insulin, like especially in type 2, this insulin resistance. So because they do have a smaller amount of endogenous insulin, that is sufficient to control the sugar level because the kidney is no longer excreting the insulin in the body system. And sometimes I have encountered quite a number of patients with end-stage disease, patients with no any medication to control the blood sugar level because the endogenous insulin is sometimes sufficient. So, but it will be depending on the patient condition. Yeah, but anyways, in renal patient, low dose of insulin is generally recommended because it is cleared by the renal system, and so that you will not reduce the risk of, you will not actually increase the risk of having hypoglycemia. So optimum sugar level control with insulin is very, very important because it can actually decrease even the incidence of proteinuria as well as albuminuria in patients with DM. So that is the essence. So optimum BP control is very important, and the goal BP from stage 1 to 4 is like below 130 to 80 millimeter mercury. Then for stage 5 CKD, if a patient is reaching dialysis less than 140 to 90, and if a patient is actually like before this and after hemodialysis, this is our goal. But how do we control the BP of the patient if they are having CKD? What is the drug of choice? What are the drug of choice? Saida.
Will you use ACEIs?
So why we use ACEIs?
They are renal protective.
They are renal protective, yes. So if a patient is actually having CKD plus DM, ACE inhibitors are the gold standard in the management because they are renal protective by reducing the protein excretion. So, okay. So that is why we're using. Okay. Question?
there's a slide that you say we should avoid ACEIs, ARBs, and beta blockers, and now we're saying ACEIs are the ideal drug of choice.
Yeah, good question by the. But remember, ACE inhibitors are usually avoided when the serum creatinine is very high or when the potassium level is actually like rocketed, like very extreme high level of potassium level. And we use ACE inhibitor in CKD patient, but we have to monitor because they can increase the risk of hyperkalemia, and apart from that, they can actually reduce the glomerular filtration rate. So that is why ACE inhibitors are a drug of choice in hypertensive CKD patients, but we have to actually control tightly if the potassium level is very high, and you have to hold the treatment. Otherwise, it is not an absolute contraindication to use. But the slide I mentioned before is just generally you need to actually like monitor. For ACE inhibitors, you need to really monitor the potassium level, and otherwise it is not an absolute contraindication. But I will come later when we don't use. But one indication is when the potassium level is very high, we have to even stop ACE inhibitor. But when the potassium level is actually within the normal level, we need to continue ACE inhibitor because they are renal protective. I don't know whether you got the information. Huh? Did I answer your question?
Yes, thank you.
Yes. Huh? So it does not mean that an absolute contraindication. Remember, when a patient is having, when you reduce the BP, you're actually reducing proteinuria. And that means we're actually decreasing the rate of progression of kidney disease. That is why optimum blood sugar control is commonly recommended. And most of the time, combination therapy is usually required to achieve the target goals of BP. So I don't think so. I'm going to talk about ACE inhibitors and ARBs much. They are very important. Okay, good.
Before we go to these drugs, what exactly happens during hemodialysis?
During hemodialysis, you are saying what will happen exactly during hemodialysis?
Like what is hemodialysis and what is its role in this? Like we've seen, it's there among the management. So my question is, what role does it play?
Okay, good. Yes. Okay, good. Good question by the way. Hemodialysis is, in fact, I already captured hemodialysis at the end of CKD, but since you have already raised the question, the role of hemodialysis is normally serve as an artificial kidney. Like if the kidney is not working, if the kidney is not working, by the way, like in stage 5, the stage 5 means like there is no nephron that is actually working kidney's function because the GFR is already less than 15 ml per minute, means the kidney requires replacement therapy. So these replacement therapies use artificial kidney, that is dialysis, or we use or do transplantation. So those are the options. So the role of hemodialysis is it actually replaces the function of the kidney. That means the moment you are actually dialyzing or the blood, remember during hemodialysis, what will happen is normally you withdraw blood outside the circulation, then you filter with artificial kidney. So that is like a filter. So it removes the nitrogenous wastes, it removes excessive electrolytes, and it removes excessive acids like hydrogen ion. Then after filtering, like the blood will come back to the circulation. So the patient is actually have two settings in the blood circulation. One set is like the blood is taken to dialysis. The other set is actually after filtering, the blood will bring back to the circulation, but that blood is actually clean from any metabolic wastes, which is toxic. so mainly heterogeneous wastes. So the role of hemodialysis is just replacing the kidney function artificially. Yes, so that it works normally at the kidney function, but primarily the primary role is mainly eliminating any excess metabolic wastes, but it does not produce erythropoietin, of course. Huh? Did I answer your question?
Yes, you did. Thank you.
Oh, okay, no problem. By the way, if we get like if this COVID era in this, like because most facilities they do have dialysis center, so the probability of visit is really very high because I think so far like almost all public facilities they do have dialysis center. Okay, good. So ACE inhibitors in ARDBs, the reason I mentioned before, they are very important class of drugs. You can actually even see they greatly reduce proteinuria, 35 to 40% as compared to other antihypertensive agents because they do have a high degree of potential to reduce protein excretion. This is the drug of choice for all patients with CKD. But remember, for end-stage renal disease, there is no evidence to use ACE inhibitors in ARBs because the kidney is totally failed. We have actually like, I think it is in Machakos, or I don't know. No, it is not in Machakos, it's in KNH. Yeah? We had actually like a big debate between the resident and the pharmacy team about this issue. So like there are some physicians, they are saying, because the kidney is already failed, like the kidney is already failed. So what is the problem of actually giving ACE inhibitors in the ARBs to control the blood pressure? That is actually their thought. But when you look at the evidence-based clinical trial, there is no actual evidence. It can even worsen the condition. So, so far, there is no evidence to use ACE inhibitors in ARBs in end-stage renal disease. That is why we need to use any other medication. So, like their thought is not like based on their evidence-based, and mostly they're using calcium channel blocker in cases of managing hypertension in advanced stage of renal disease. But for stage 1 to 4, we can use ACE inhibitor. Yes. Okay, good. So regardless of by their BP, as long as they do have documented evidence of proteinuria, we need to use ACE inhibitors or ARBs because diabetes is associated with an early onset of microalbuminuria, and all patients with DM should receive an ACE inhibitor for ARBs regardless of their blood pressure. So that is the recommendation. So what kind of ACE inhibitors we are having in the market? Enalapril, like the leading, then ARBs, losartan is available in the market. But as I said before, you can actually even see the titration based on the renal function test is really very, very important. But as I mentioned before, if the serum creatinine is significantly elevated, avoid whole ACE inhibitor because it can kill the patient because of electrolyte disturbance. Then how do we assess the outcome evaluation? Like serum creatinine, potassium level, and BP should be done within 1 week after initiation of ACE inhibitors or ARBs. But as I said before, you need to discontinue the medication and switch to another agent if there is a sudden increase in serum creatinine, if you have hyperkalemia, if a patient becomes hypotensive. Okay, so in such a scenario, we are supposed to hold the treatment. If the target BP is not achieved, we need to add another agent. So, but mostly thiazide diuretics are commonly recommended. So this is the treatment algorithm of hypertension in CKD patient. So our goal is mainly 130 to 80 millimeter mercury. So if the BP is greater than 15 to 20 systolic and over 10 millimeter mercury over the goal BP, we need to combine step 1 and step 2. So step 1 and step 2 means combination of ACE inhibitors in ARBs, diuretics should be considered. If the goal BP is like above, it is above like 15 to 20 or 10 diastolic. So if there is an elevation by this number, we can actually combine step 1 and step 2. But mostly, ACE inhibitors are the drug of choice. And if we don't achieve the target goal, we need to add diuretics. But remember, diuretics I mentioned, if the creatinine clearance is actually less than 30 ml per minute, thiazide diuretics are not very efficient. They are not very efficient to remove excessive fluid. So if the creatinine clearance is actually greater than or equals to 30 ml per minute, we can use thiazide diuretics. So thiazide diuretics are a drug of choice. But if the creatinine clearance is less than 30 ml, loop diuretics are very, very efficient. That can be considered. That is why, but from thiazide-like diuretics, metolazone can be considered even when the creatinine level is less than 30 ml per minute, but mostly loop diuretics are commonly recommended. Now, after that, in case if we are not able to achieve our target blood sugar level, we can add also even long-acting calcium channel blocker. So initially, we combine ACE inhibitors plus diuretics. Then if we are not able to achieve our target blood pressure, we can actually combine calcium channel blocker. So still, we need to monitor with the patient. Then if still we are not able to achieve our goal, maybe we can add low dose beta blocker is commonly recommended, and the algorithm will continue even including adding of any other long-acting alpha blocker and even centrally acting alpha agonists such as clonidine. So those are the drugs normally, and will continue in like the algorithm will continue depending on the patient response, and the patient will end up having multiple antihypertensive medication. But the initial treatment should be initiated with ACE inhibitors, and we titrate the patient. So this is how we are managing hypertension in CKD patient. Then now, let me take you through the management of complications of CKD. So I'm going to take you through about how we are managing when there is an edema. How do we manage hyperkalemia kidogo, because we have already covered it in a KI, and anemia of CKD. Then secondary hyperparathyroidism is also be part of the complication, and metabolic acidosis, urine protein, and pruritus. And finally, we'll actually discuss about the role of hemodialysis in stage renal disease patient. So when you are discussing about CKD, you need to know about the complications of CKD. So remember, sodium and water imbalance is a common condition in CKD patient. So we need to actually treat. We need to treat because the patient will end up having edema because of sodium and water reabsorption. And apart from that, the patient will be unable to concentrate the urine, and as a result, the patient will have even nocturia in a patient with CKD, but mainly it is usually occur even as of the stage 3 CKD. Okay, remember what will happen when there is a sodium and water, when there is an imbalance or impaired sodium and water hemostasis, the patient will end up having edema. Those are the major issues. So as a result, the blood pressure will be elevated, and mostly the sodium levels remain within the normal level. But as a result of this impairment, edema is very common. So in case of severe edema, in CKD patient, loop diuretics are a drug of choice. Loop diuretics are a drug of choice, and mostly we use Lasix ranging from 20 to 80 milligram pure daily is the frequently used doses to relieve edema in this patient population. But as I mentioned before, if the GFR is less than 30 ml, we don't use thiazide diuretics. It is not very effective. Otherwise, thiazide diuretics are also be used if the GFR is above 30 ml per minute. Those are like the general ideas of the use of diuretics in this condition. Then after that, what do? We monitor the edema after initiation of the diuretic therapy, which is very important. So make sure we need to avoid any dehydration. So because of the severe diuresis, so adequate amount of fluid intake is usually recommended so that the patient will not undergo dehydration. So you monitor in ways. You monitor the edema. How? You just look at whether the edema is resolved. And apart from that, you measure normally the weight of the patient. Weight of the patient is really a very important parameter that can actually give you an important information whether the drug is really, whether the diuretic is really working or not. Then now, if there is an impaired potassium hemostasis, what will happen? Remember, kidney is the primary organ for potassium excretion. Like it secretes 92-95% of daily dietary intake of potassium is by the kidney. So if the nephron mass is reduced, means now the patient will end up having edema, because like about 90-95% is excreted by kidney, but the remaining 5% is excreted by gastrointestinal tract. Okay, but the GIT system will be overwhelmed when the potassium level is actually very excess, and it can only excrete only 5% of the available potassium. So because of this reason, the potassium level in the serum will be elevated. And remember, more than 50% of the patient with stage 5 CKD is primarily affected by hyperkalemia. So it's really, hyperkalemia is really very common. You know, sometimes by the hyperkalemia even can cause tremor. Yeah, the patient is actually become even shaking as the result of hyperkalemia. And we have seen one patient in a hospital. Okay, as I've said before, the nephron mass decreases, so the distal tubule secretion, GI excretion, will be increased because of aldosterone stimulation. So this is just compensatory mechanism. So between stage 1 to 4 patients, the serum potassium concentrations are within the normal range because of, like, there are some nephron that can actually even to overactivate the aldosterone, and it produces or it promotes excretion. But the problem is, if a patient becomes advanced stage 5, like the GFR is usually for like less than 20% normal. So it is now beyond the capacity of the kidney to eliminate excess potassium. So because of this reason, what will happen when nephron mass and renal potassium secretion is so low, then the capacity of the GI tract to excrete potassium has been exceeded. Then after that, you will see the potassium level will be very high in the serum. So most of the time, the risk of hyperkalemia between stage 1 to 4 CKD patients are minimal, but for end stage, it is really very high. Then what will happen when there is an impaired potassium level? Okay, you will see an ECG changes mainly on the T wave. Those are very important. And apart from that, I've already mentioned about the basic clinical features of hyperkalemia, like the ECG changes, then the patient become weak, bradycardia is really lethargy. Those are the most common presentation when a patient is having hyperkalemia. Okay, so generally speaking, the lab test is the one which is very important to confirm and it is usually above 5.5 millimeter mercury. Okay, good. Now, how do we treat hyperkalemia? How do we treat hyperkalemia? Geoffrey. Geoffrey, I'm waiting the answer. Okay, any other person?
Sorry, repeat the question.
So how do we treat hyperkalemia? High potassium level. Okay, any other person? We've already discussed Vitalis. Vitalis. Okay, Venetia.
Yes, sir. I'm here.
Okay, yeah. So tell us, how do we manage hyperkalemia?
I know for you can decrease the dietary intake of
Okay, yeah,
potassium.
dietary intake. Okay, yes, yeah, that one is just like part of the like the combination modalities. Huh? We can actually reduce protein intake. Sorry, potassium-rich diet, avocados, the mangoes, okay, orange, etc. Any other modalities of treatment?
Diuretics.
We can which diuretics?
Furosemide.
Okay, loop. Okay, loop can be used, but despite the onset of action is actually very slow, and we cannot use for emergency management. But it is part of the strategy. Any other person?
We can administer glucose so that it can absorb so that there can be removal of extracellular potassium into intracellular.
That is shifting, yeah. Okay,
Yes.
good. Before dextrose with insulin, do we have any modality of treatment we need to give like emphasis? What is the emergency management? What should be given or what should be treated first? This is very common, by the way, in medics. So like the most urgent should be treated first and the other will follow. The other will follow. Okay, I think because of time, maybe let me brush you through, but we have already mentioned about the treatment modalities of hyperkalemia when we are discussing about AKI. So non-pharmacological, maybe patients should be avoid abrupt increase in dietary intake of potassium. That is true. Then dialysis can be considered in severe hyperkalemia, but the most common pharmacological modalities in the management of hyperkalemia is you just manage the cardiac impairment first. So the cardiac effect of hyperkalemia should be given priority because hyperkalemia can cause cardiac arrest. So you just give calcium gluconate or calcium chloride, but mostly calcium gluconate is usually considered, and it is usually 1 gram intravenously, and it can be repeated depending on the patient's response, but mostly single dose is sufficient. So the cardiac effects will be treated with calcium gluconate so that we can maintain myocardial stability. Then after that, the next strategy of treatment is shifting of potassium into the intracellular compartment. Remember our last discussion in AKI, when the potassium level in the serum is very high, the cardiac tissues are very sensitive as compared to a potassium level inside the cell. So temporary shifting is very important and mostly is usually done insulin 5 to 10 units plus 50 ml or 50% dextrose to counteract the hypoglycemic effect of insulin should be given, because those class of drugs, they do have an activity to activate sodium potassium ATPase so that they can increase shifting of potassium into the cell. Then even albuterol is by this salbutamol. Salbutamol nebulizer can also be considered for shifting of potassium. So when you give this medication, this will decrease the serum potassium level within 30 to 60 minutes after treatment. That is why this class of drugs are very good for emergency management. Then the next step is we need to use potassium binding agents. So one example is sodium polystyrene sulfonate. So this sodium polystyrene sulfonate it is just like an ion exchange resin. So they actually promote excretion of expression of potassium because the sulfonate have sodium, so that there is an exchange. When there is a sodium, when you administer sodium, there is an exchange with potassium, and it promotes elimination of potassium from the GIT. So this reason is actually having slow onset of action. Remember, even the onset began within 2 hours. That is why they are not commonly used like at the front line in the management, but they have to be considered in the long-term management. And 50 to 30 milligram per day orally can be considered. So the maximum effect is usually seen up to 6 hours after administration of the patient. So because of this reason, its utility is usually very limited in severe condition. So calcium gluconate shifting, then after that potassium binding reason should be considered. Okay, there is also even the role of diuretics, as someone said. Look, diuretics can also be considered, yes, in the management. And apart from that, even we do have synthetic mineralocorticoid, which can replace the action of aldosterone. So this can be considered, but the major problem is because of significant water retention as a result of fludrocortisone, this class of drugs is not really tolerated because of edema and hypertension in most of CKD patients, so is not commonly considered. So the management are the one I mentioned. By the way, if you are asked in the exam, if you mention this one, it is not really like appropriate treatment modalities, because I just mentioned it. This is another option. Otherwise, this is not in the front line in the management. So when you are asked to outline or to maybe formulate a treatment plan for the patient, you need to start from the front line medication. Okay, then after that, how do we monitor the outcome? Look at the ECG, and in a patient with cardiac abnormalities, and until the serum potassium level drops like less than 5 milliequivalent per liter. Okay, then evaluate the serum potassium and glucose level within an hour in a patient who received insulin plus dextrose therapy. Then evaluate the serum potassium level within 2 to 4 hours after treatment with the sodium polystyrene sulfonate. This is the potassium binding reason. Then we can repeat the dose of diuretics or SPS if necessary until the potassium level is less than 50 milliequivalent, 5 milliequivalent per liter. So this is how we're actually monitoring the outcomes of the treatment. Okay, now this is how we're managing. This is how we're managing CKD. Managing hyperkalemia in CKD patient. So the next complication is anemia in CKD patient. So why anemia in CKD patient? Why anemia in CKD patient? Marion. Okay, Laura?
I think it's because the kidney makes erythropoietin. So when the kidney is damaged, the erythropoietin will decrease, and therefore the RBCs will also decrease,
Okay.
causing anemia.
Okay, exactly, yes. So kidney produces less around 90% of the hormone erythropoietin. So this is one of the endocrine function of kidney, which stimulate RBC production. So if a patient with CKD, a patient with CKD should be evaluated for anemia if the GFR falls less than 60 ml per minute. So if the GFR is actually below 60 ml per minute, mostly it is advisable to assess whether the patient is actually having anemia or not. Like before that, it's very unlikely. Okay, this is the primary cause. So the primary cause is due to deficiency of the erythropoietin. So you can actually even imagine the anemia decreases even oxygen delivery to the renal tubule. So this promotes release of inflammatory vasoactive cytokines, which can actually even increase the progression of the disease. So even anemia in CKD patient can actually even worsen the condition. Then apart from that, when anemia develops in CKD, then there is decreased oxygen delivery and utilization. Then this can even increase cardiac output and left ventricular hypertrophy, and this actually increases cardiovascular risk and mortality in a patient with CKD. Even anemia by this can cause even heart failure ultimately. Yeah, so you can actually even see anemia treatment is really very important. Then apart from that, the degree of anemia increases when the stage of the disease increases. You can actually even see if a patient is actually having stage 3, like the risk doubles. Huh? If a patient is having stage 4, the risk actually becomes like 4 times. Huh? But even when the patient is having stage 5, the risk of anemia is actually like 10 times. So the probability of anemia in stage 5 CKD is very common. So you can't even miss anemia in stage 5 patient. So generally speaking, what causes anemia in CKD patient? The primary factor is decreased erythropoietin production, but it is not the only factor that causes anemia in CKD patient. The next parameter that causes anemia is uremia. Remember, uremia can cause bone marrow suppression, and uremia even can actually decrease the lifespan of RBCs like as low as 60 days. As low as 60 days. And the normal lifespan of RBCs are 120 days. So they can actually reduce to 60 days. So you can actually even see uremia is one risk factor. And apart from that, iron deficiency and blood loss from regular laboratory testing and hemodialysis is very common in CKD patient, which contributes to have anemia. So why iron deficiency? Because there's a lot of inflammation in the GIT. That inflammatory reaction even sequester iron utilization. And apart from that, because of bleeding, there's loss of iron, so the patient will end up having what? Anemia. So those are the most common risk factor that causes anemia in CKD patient. So I think for the rest, we'll get information from the group presenter of anemia. So what are the general clinical presentation when a patient is having anemia? The patient will have fatigue and decreased quality of life, shortness of breath, and even cold intolerance is very common, and palpitation. Those are like the major clinical features of anemia. So how do we know whether the patient is having anemia? We look at the hemoglobin level, but we can also use erythropoietin level, but this test is not commonly done in our setting. So we usually rely on the hemoglobin level. So what is the goal of managing anemia in CKD patients? So as much as possible, we need to increase the hemoglobin level above 11 grams per deciliter. So how do we manage anemia in CKD patients? Remember, in CKD patient, iron supplementation is the front line in the treatment of anemia. So we just do replace iron because iron deficiency is very common. So if iron deficiency is not, if anemia is not restored by iron supplement now, they are going to continue with erythropoietin replacement therapy. But most of the time, you have to start with first line treatment. Usually started with anemia. Iron supplementation. So when iron supplementation alone is not sufficient to increase hemoglobin level, now you can continue erythropoietin stimulating agents can be used so that they can replace erythropoietin. But remember, one thing to note, if the hemoglobin levels are actually below the goal, we can actually supplement iron. But whatever lower amount of hemoglobin, iron supplement should be is not recommended when a patient is infected. So why iron supplement is not infected? In fact, like the risk outweighs the benefit. So you better not treat anemia instead of giving iron supplement in case of infection. So what is the reason, by the way? What is the reason? What is the reason? Okay, anyone who can try? But did you hear the question?
No.
So why, if you see here, if iron supplementation is recommended if the hemoglobin levels are below the goal, that is like below 11, but avoid it if the patient is infected. If a patient is having any infection, like despite they are having anemia, you need to avoid iron supplement until the patient is actually cleared from the infection. So what is the reason? Okay, you can try, yeah?
Can some drugs cause chelation?
Okay, good. Yeah, chelation is mostly for the oral form. To give them IV injection, there's no issue of chelation. Any other?
What about those drugs that are eliminated by the kidney? If you have chronic, will there be the buildup of toxin in the body?
Of course, yes. That is why we need to clear those toxins, by preventing the progression of the disease.
Yes.
Okay, I think because of time, the major problem, if you actually replace iron in the presence of infection, iron is the most important nutrient for growth and proliferation of the microorganism. So if you replace iron means you're actually even promoting the infection. So you treat the infection first, then you give iron supplement. So avoid any iron supplement during infection because iron promotes or exacerbates the proliferation of what? The infection. That is why we need to avoid. So even in this context, they are saying the like evidence-based clinical trial saying it was saying like the risk outweighs the benefit. So you better not treat anemia instead of actually giving iron supplementation in the presence of infection. So you need to know, by the way, any iron supplement is not recommended during infection. By the way, do you know during infection time, there is an endogenous mechanism that can sequester iron so that the microorganism will not access the iron store during infection. So there is an endogenous mechanism. But if you give them extra iron exogenously means actually increasing the risk of infection. So because of this reason, it is not generally recommended. Okay, then use of erythropoietin increases iron demand for RBC production. And apart from that, another point to note, the moment you are replacing erythropoietin, then the demand for iron for RBC production will be increased. That is why in the presence of erythropoietin supplementation, you need to give iron supplementation so that you can actually correct and maintain adequate iron store to promote RBC production. So erythropoietin by itself will not actually like promote production without actually supplementation of the iron. That is why when you are giving erythropoietin, give iron supplement, which is very important. Okay, good. So oral iron supplement is the first line treatment for iron supplementation for a patient who is not receiving hemodialysis. So if a patient is not receiving any dialysis, you need to give oral supplementation of iron, and ferrous sulfate is like the most widely available class of drug that can be considered for a patient for replacement. At 10, 100 to 200 milligram pure divided dose is usually recommended. A minimum of 3 months treatment is usually required when it is given orally. But the way, if you don't replace iron, like for less than 3 months, the probability of replacing, there is high probability of depletion of the iron store after 3 months of treatment. Okay. Oral iron supplementation is generally not effective in maintaining adequate iron store in a patient who is receiving ASA because, so like if a patient is receiving, by the way, erythropoietin stimulating agent, like the oral form of administration is not generally recommended because of poor absorption. Iron is actually having poor absorption, and there is also increased need for iron with ASA therapy make very necessary for iron supplementation. So because of poor absorption, like the iron absorption in CKD patient is really very poor because of activation of the inflammatory reaction that can even affect iron absorption. So in such a scenario, we need to give IV replacement therapy, and mostly a total of 1 gram. IV iron is usually recommended, but it should be in divided doses. Should be given on divided doses. So like for non-hemodialysis patient, mostly we give oral supplement for 3 months. But if a patient is actually undergoing hemodialysis, we need to actually give in the form of intravenous route of administration because of the urgency of the need. Okay, then after that, maintenance doses are often used in a patient receiving hemodialysis. Remember, there is a lot of even loss of iron during dialysis, so we need to give maintenance dose. And mostly, iron sucrose is usually administered weekly, like during the dialysis session. Like we need to give 20 to 100 milligram per week. So, but mostly 100 milligram a weekly dose of iron sucrose is usually commonly recommended. Okay, then remember, IV iron preparations are equally effective in increasing iron store. So like all iron preparation actually have the same efficacy to restore iron store. But the major problem is anaphylactic reaction with all IV preparations are very common, but is most common with iron extract. Like what we don't like giving iron preparation in injection form is actually because of anaphylaxis, but it is very common with iron dextran. But so this time around, the use of iron dextran is not really common. And if it's mandatory to use it because of availability issues, you need to give test dose before you give them the full dose, and you monitor anaphylactic reaction. Then after that, you actually give in divided doses, like 1 gram course of iron. Like if you give them IV, you give them 1 gram, but it should be in divided doses. If you give them maybe for non-dialysis patient, you need to actually give in 5 doses. You just give in 5 doses in the interval of 14 days. In the interval of 14 days, you just give 5 doses. Yeah, but the total dose of iron should be 1 gram. Yeah, it should be 1 gram. Remember, the probability of iron deficiency anemia is very minimal because unless the store is depleted, there is no any physiological parameter or any pathologic condition that promote the excretion of iron. I think you will get more information from the group presentation. Okay, then you can actually look at it. The serum ferritin and the transparent saturations are very important parameter so that we can be used to monitor the iron store. Ferritin level will tell you about the iron store, and transparent saturations also will tell you about the iron level in the body system. So those are very important monitoring parameter that can assess when we are replacing iron for a patient who is having anemia and CKD patient. Remember, if the hemoglobin does not increase after a course of IV iron, like that is 1 gram course of IV iron, an additional of 1 gram of iron may be administered. That is the recommendation. Okay, then when do we use erythropoiesis stimulating agents? Remember, abnormalities found during anemia workup should be corrected before initiating ASA, particularly iron deficiency. So before you give ASA, you need to correct iron deficiency first. And that is why iron supplement is the front line in the management of anemia of CKD. If the hemoglobin level is below 10, when all other causes of anemia has been corrected, now we need to assume the patient will have probably erythropoietin deficiency, and we need to give erythropoietin supplement. So what are the erythropoietin available in the market? We do have epoetin alpha and the epoetin alpha. This one is a bit of long acting. So both of them can be given. This epoetin alpha is subcutaneously, and the epoetin can be given IV or subcutaneously. You can see actually 50 to 100 units per kg. Subcutaneously, 2 to 3 times per week is usually recommended. So this is the recommendation, but the epoetin alpha is usually given once weekly. So most of the time, as I mentioned before, like all other causes should be corrected before we initiate because of the risk. Then use of this agent beyond 12 grams per deciliter level is associated with increased mortality. Remember, when you give continuously replacing erythropoietin, it can actually cause what? It can actually cause even hypertension. And apart from that, it can actually cause even increased viscosity of the blood, and the patient will end up having clot formation or thromboembolism. So most of the time, the use is generally not recommended if the patient is having hemoglobin level of 12 grams per deciliter. Okay, so this is the recommendation. So the maximum target hemoglobin should not be exceeding 11 grams per deciliter. That is the recommendation. So what is the risk? Remember, the erythropoietin stimulating agent, they can actually increase blood pressure, and the patient will end up having given hypertension. Then apart from that, they can actually cause seizure, and pure red cell aplasia can occur. So, and even it increases blood viscosity. Because of this reason, if the hemoglobin level is above 11 grams per deciliter, we need to hold erythropoietin replacement therapy. So this is, by the way, the treatment algorithm. This is the treatment algorithm of management of anemia in CKD patient. So what you can do first is you need to assess transferrin saturation and serum ferritin level. The saturation is usually between 20 to 50%. So if the ferritin level is less than 100 nanogram per ml, in non-hemodialysis patient, And if the transferrin saturation is less than 20%, which is actually very low, then you need to give IV iron in total is 1 gram a divided dose. But if a patient is not on dialysis, we need to give like oral supplement of iron, mostly for 3 months is usually recommended. Then you assess the patient. But however, if the ferritin level is between 100 to 500, and the saturation is between 20 to 30%. Now still we need to consider trial IV iron can also be considered, but still for non-dialysis patient, oral iron supplementation is actually usually recommended. It's very less expensive and the risk of side effect is actually very minimal. But if the ferritin level is above 500 nanogram per deciliter and the saturation is above 30%, don't give any additional iron. Yeah, that is the recommendation. So when do we initiate erythropoietin stimulating agent? So if the hemoglobin is actually above 10, so the only way we can initiate ASA therapy is if there is any benefit. And we need to give normally adequate information for the patient so that they need to accept the risk of ASA therapy. So generally speaking, if the hemoglobin level is above 10, is not really recommended. Then if the hemoglobin level is less than 10 gram per deciliter, now this is where we need to use erythropoietin stimulating therapy is usually recommended. So then after you administer erythropoietin stimulating agent, you need to assess the hemoglobin level, which is very important until the patient is stable. Then at least monthly in CKD dialysis patient, then after that every 3 months in dialysis CKD patient, and you monitor iron store at least every 3 months. So if the hemoglobin level increases after you give replacement therapy with erythropoietin, if the hemoglobin level is above 1 gram per deciliter, what you can do is normally you can actually reduce the dose by 25% or interrupt the dose by 1 gram per deciliter in a 2 weeks period, or it exceeds above 11 gram, you need to reduce the dose by 25%. If you don't see any change, you are supposed to increase, especially after 4 weeks later. If you don't see any change in hemoglobin level, you need to consider a 25% increase in the dose of ASA. So in summary, those are the most important parameters. So what guides you is the hemoglobin level of the patient, and what guides you is actually the saturation level of transferrin. So if it is above 11, generally speaking, you hold the treatment, or you need to reduce the dose by 25%. So those are the general recommendation if a patient is actually having this issue. So this table is to show you about the replacement therapy, of iron. So as I mentioned before, iron sucrose is like the most common. This one is the most common therapy in our setting, and most of the time 100 gram IV therapy 3 times daily, 3 times per week during hemodialysis is usually recommended for 10 doses during the dialysis session. So if a patient is undergoing dialysis, we need to give replacement therapies are usually recommended, but still the maximum dose we can give is 1 gram. But for non-dialysis CKD patient, and if you are giving IV, you give them 20 milligram IV for 5 days in the 5 doses in the interval of 14 days, but still you are giving what? 1 gram maximum dose. So if no improvement, you can actually repeat the dose. But if the transferrin saturation is above 50%, and ferritin level is above 500 nanogram, you need to hold the therapy. That is the recommendation. Then from all IV iron preparation, the iron dextran, the possibility of anaphylactic reaction is very high, and there is a need of test dose administration. So in summary, I'm just finishing for today. So in summary, what do we do, or how do you assess the outcome? Evaluate the hemoglobin monthly when this therapy is initiated. Then ASA doses can increase monthly if the hemoglobin level is below the goal. Then once stable HB is achieved, now you can actually do it every 3 months. If a patient is actually receiving ASA therapy, you monitor the iron store at least every 3 months. So this is all about what I have for today. And sorry because I took time, because you just joined late after 10 minutes. That is why I was just adding 10 minutes. So this is all what I have for today, and we'll actually finish it on Friday. Sorry, on Thursday. The remaining complications of CKD. Any question